Welcome back to part 2 of disorders of motor function. And we're going to talk about spinal cord trauma. This often leads to paraplegia or quadriplegia. And that means if we're talking about paraplegia, we can't move limbs such as just our legs, or we can't move just our arms. Quadriplegia would be all of the limbs aren't able to move, and that depends on the location of the injury to the spinal cord and, of course, the extent of the injury. So one type of injury is called a hyperextension injury, and this is when the forehead is struck and driven posteriorly, or it doesn't necessarily have to be struck. For instance, you could be in a car accident, and what happens in that car accident is, let's say, somebody's driving at 80 miles an hour, and then immediately the car stops, and that could be because, let's say, it struck another vehicle. And so the body is still moving forward at 80 miles an hour, but when the car stops, the body is pushed back. And since the neck is very delicate, that head could go forward and then thrown back with tremendous force. And you can have this hyperextension injury. It could also happen, for instance, diving, where somebody dives head first into an area of shallow water and their head is struck backwards. It can tear the ligament called the anterior spinal ligament, and the spinal cord may contact the vertebral body. So the most common hyperextension injury is whiplash. And the symptoms could include neck stiffness, pain that worsens when the neck is moved. You get headaches and dizziness. Of course, your range of motion is going to be limited. You may have myofascial injuries, such as to the ligaments and muscles, shoulder pain, back pain, and then paresthesia, which is a burning or prickly sensation. Now, of course, really bad hyperextension injuries kill, because they're going to tear the spinal cord and cause death. You can also have that paraplegia and quadriplegia from this. So with whiplash, you're looking at the hyperextension type of injury going on here, compression in the back and extension here. And then we have what's also called a flexion injury. And the hyperflexion injury is when the head or shoulders are struck from behind by an object of considerable weight or from a fall. And so you can see that you have bulging here of these discs, and then you can have injury to the spinal cord itself. Concussions are also a type of trauma, and you can have anything from mild to severe concussions, and the injury can be reversible, and contusions can occur, which is bleeding. Severe trauma with hemorrhagic necrosis, edema, even softening of the cord is called myomalacia, or there's blood in the cord, which is hematomyelia. And of course, that's going to cause all kinds of issues to the spinal cord. With concussions, you can also have lacerations, which are cuts or tears in the spinal cord, as well as transection, or completely cutting the spinal cord. And this is a cervical contusion right here to the spinal cord. Basically, contusion is bruising of. So we also have disorders arising in the basal ganglia, and some of the characteristics of these disorders are going to be involuntary movement, alterations in muscle tone, disturbances in body posture. So some of the types of involuntary movements would be like a tremor. So this is trembling or vibrating. Tics are a habitual spasmodic contraction of the muscles. Most of the time, tics are going to happen in the face. You also have chorea, which is irregular writhing types of movements, athetosis, worm-like or twisting movements, and I'll show you some video on this a little bit later. Bulismus is violent flinging of the limbs, dystonia, abnormal posture, dyskinesia, which is this bizarre wriggling types of movement, and it's specifically tardive dyskinesia. This develops due to the use of antipsychotic medications. So the first one we're going to talk about is Parkinson disease. And the characteristics is 0.3% of the general population, or about 80,000 people, have Parkinson's disease. Usually, not always, there can be some early onset, but there typically begins later in life after the age of 50. It affects men twice as often as women, and the disease usually lasts for 10 to 20 years before taking the person's life. Clinical syndrome is called Parkinsonism, and we'll talk about that. And this was named after James Parkinson, who labeled the disease in 1817 as a shaky palsy. So Parkinson's disease has a lot to do with the substantia nigra in the basal ganglia. And remember, the substantia nigra produces dopamine. This is a dopamine pathway. And what we see is degeneration of the neurons in the substantia nigra, so we can't produce as much dopamine. Now, the causes of Parkinson's disease are unknown. We don't know if it's environmental or if it's genetic or what it is. Early symptoms are the tremor, more rigid, slower movement, slower reflexes. Later, we have cognitive problems that also leads to dementia and dyskinesia. So if we look at the person's brain, which of course we can't do until autopsy, we do see the atrophy of the substantia nigra. But one of the other things that we see are Lewy bodies, which we've talked about before, and these are inclusions in the neurons. So if you look here, you can see the buildup of these Lewy bodies in these neurons. And you know, we talked about this before, what's referred to as Lewy body dementia. So Parkinson's disease, you can see this is the substantia nigra here, and over here you can see that it's not nearly as dark, so this is atrophy of these neurons of the substantia nigra. So some of these symptoms also we see of Parkinson's is what's referred to as cogwheel type movements. So that instead of that person having nice smooth movements, they're more like a ratchety type of movement. So instead of, like, let's say taking your hand, which is hanging down by your side, and bringing it up, bending the elbow to touch your shoulder, you can do this in one nice swift type of movement. But a person with Parkinson's disease, as they move their hand from their side to their shoulder, it's like they move it up a little bit and it stops, and move it a little bit more and it stops, and a little bit more and it stops, until eventually they reach their shoulder. And this is that cogwheel type movement. They also have the bradykinesia, which is slowing the ability to perform movement. So it takes them a little bit of time to start, and it takes them much more time to get through that movement. Difficulty walking, as well as their posture, and then they can develop neuropsychiatric problems. You might know some people who have Parkinson's who are famous, like Michael J. Fox. Muhammad Ali developed Parkinson's disease later in life, and a lot of people attributed that to, of course, his boxing and the fact that he was hit in the head a lot. Michael J. Fox, there is some thought that it's genetic because he is Jewish, and the type of genetics that he has seems to have higher rates of Parkinson's disease. So let's take a second and watch a video about Parkinson's.
Parkinson's disease, or PD, is the second most common neurodegenerative disorder after Alzheimer's disease, and affects 1% of individuals over the age of 65. It is classified as a hypokinetic movement disorder and occurs due to degeneration of dopaminergic neurons that project from the substantia nigra in the midbrain to the basal ganglia. The initial precipitant of neuronal death is unknown, and by the time symptoms emerge, between 50 to 80% of dopaminergic neurons have already died. The cardinal features of PD are tremor, rigidity, akinesia or bradykinesia, and postural instability, easily remembered with the mnemonic TRAP. The most essential feature for diagnosis of PD is bradykinesia, which is characterized by a reduction in both speed and amplitude of voluntary movement. This is most striking during repetitive movements like finger tapping, where taps are slowed and become progressively smaller in amplitude, or writing, where letter size decreases across the page, also known as micrographia. Bradykinesia is also manifested as a loss of facial expression, or hypomimia, reduced vocal volume, or hypophonia, and slowing with a variety of other activities, including walking, dressing, and turning in bed. The tremor in PD is typically a unilateral, rhythmic, resting tremor between 4 to 6 Hz and can classically start as a pill-rolling tremor of the thumb and forefinger. Rigidity is an involuntary muscle tone present throughout the range of movement and can be tested by passively moving the arm, neck, or leg. If rigidity is smooth and consistent throughout, it is called lead pipe rigidity. If, however, there is a ratchet-like quality, it is called cogwheeling, which is thought to be due to rigidity superimposed on an underlying tremor. Parkinsonism also causes characteristic gait abnormalities like stooped posture, small shuffling steps, reduced arm swing, and freezing. So make sure to ask your patients and watch out for falls. PD is treated with levodopa, which is a precursor of dopamine, the neurotransmitter that is deficient in PD. An excellent response to levodopa in a patient with asymmetric, tremor-predominant Parkinsonism is supportive of the diagnosis of PD. It is important to keep in mind that PD is the most common form of Parkinsonism, but patients may develop Parkinsonism from other causes, including medications such as antipsychotics, other degenerative disorders such as multiple system atrophy or progressive supranuclear palsy, and Wilson's disease, which causes copper deposition in the basal ganglia.
Our next disease is Huntington disease. This is an autosomal dominant mutation on chromosome 4. So one affected copy of the gene is enough to cause the disease, which means there's a 50% chance of the children in the next generation to be affected by this gene. Huntington's disease is due to increased CAG in our DNA. So remember, ATGC, part of the DNA, there is a segment CAG that can be copied in this chromosome 4 from like 27 to 35 times. You get CAG, CAG, CAG over and over and over again. And so what happens is you get this protein that's inappropriate. And now this protein starts to accumulate in the neurons of our basal ganglia. And it decreases the inhibitory effects of the basal ganglia. So remember, I told you there's some areas where there's so much stimulation going on all the time that you actually have to inhibit that. And so this inhibitory effect goes away, and now you have too much motor movement. And so you have an issue with this person. We'll talk about what that motor movement looks like. It begins around the person's 30s to 40s, and it progresses over about 10 to 20 years before taking the individual's life. So this is a very rare neurodegenerative disease. Symptoms for Huntington's would include progressive CNS involvement, which has to do with movement, cognitive issues, mood issues. And so if we look at them in early versus late symptoms, early symptoms would be a lack of coordination and an unsteady gait, whereas late symptoms would involve that chorea, the involuntary writhing, the athetosis, which is kind of like snake-like movements of the limbs, and then you have psychiatric symptoms including dementia. So this is from decreased GABA and acetylcholine production, which is going to inhibit the excitatory information coming from the basal ganglia. And so you can't do that inhibition. Also, there's increased dopamine production, which is going to stimulate the basal ganglia even more. And we talked about usually death occurs within about 10 to 20 years of this diagnosis, and mainly it's due to aspiration pneumonia because the person can't breathe appropriately, and unfortunately suicide is a big deal with Huntington disease. All right, so let's watch a video now on Huntington disease, and we can see in this video how the movements are so drastically changed in the person.
Washington across the Delaware, and it's worth it. I'm sorry that you're upset. I died with the people I should have died with. It was sad. There's a few times when tears hit the page. It's weird to the last. I'm going to call people, but there's a letter they're going to get from me explaining why it had happened.
Did you think they wouldn't understand?
No, they don't understand. The kids probably wouldn't, but I think eventually they would.
And that's a piece of paper that they would have for their whole life.
Yes.
That piece of paper would be the last advice they ever got.
Yes.
From their dad.
Yes.
What'd you say?
Like I talked about their weddings.
So this really shows you that movement, that chorea and athetosis that is occurring in this individual. Multiple sclerosis is a demyelinating disorder of the central nervous system. We don't know the etiology of multiple sclerosis, but we do think that it has an autoimmune component to it. So a variety of motor, sensory, and cognitive problems occur in people with MS, and this is considered a type 4 hypersensitivity reaction. Remember, that has to do with T cells. This is a cell-mediated hypersensitivity. So what happens is these T cells get into the central nervous system, and they are able to get through the blood-brain barrier, and they start to release cytokines. And these cytokines are able to damage the oligodendrocytes. Now remember, those oligodendrocytes are the neuroglial cells that are producing myelin in the central nervous system. And so if we damage those oligodendrocytes, we can't make the myelin. Now, just to refresh your memory, myelin is that fatty substance that coats the neuron's axon, just like insulation would coat a wire. And so it allows neurological electricity, you might say, to run down that axon much faster. If we demyelinate the neuron, then that electrical information is going to slow down tremendously and potentially even stop. So these T cells, once they release these cytokines, they can also damage the blood-brain barrier even more and cause that blood-brain barrier to basically fall apart, which then allows B cells and macrophage into the central nervous system. Those B cells release antibodies that can attach to the oligodendrocytes and to the myelin, and the macrophage then bind to the antibodies, and they destroy the myelin as well as the oligodendrocytes. So this is just simply showing you the myelin around the axon of a neuron, and normal healthy myelin, and then damaged myelin. Looks like rats got in there and chewed it all up. So multiple sclerosis, interestingly enough, it can be what we would call a relapsing, remitting type of disease. And what that simply means is for a while, your patient is having symptoms and then they aren't. So let's go back to this picture just for a second. So as electrical information is moving down a neuron that is myelinated, what's happening is you're getting action potentials here in this uncovered region of the axon. But you don't have any action potentials that occur underneath the myelin within that part of the axon. Instead, what it allows to happen is very rapid movement of ions to this next section that's uncovered, which is what we call a node or a node of Ranvier. And then you get action potentials here, and then the information, the ions are rapidly pushed to the next node and you get action potentials here. Now, if I don't have this myelin covering, what'll happen is there are no gates underneath this myelin in order to actually have action potentials. If you remember, you have to have voltage regulated gates to be able to have action potentials, and under myelin, they don't exist, but I can grow them. If my myelin goes away, I can actually form voltage regulated gates in this region of my axon so that action potentials can start to occur. So with my patient, what will happen is for a while, those gates don't exist. And so I have this issue with my neuron, but then I start to grow those gates and I can have more action potentials now. However, I'm supposed to have action potentials here, and then they rapidly jump to here, and they rapidly jump to here in each node and keep on going down the axon very rapidly. But now, if I have all these voltage regulated gates where the myelin used to be, I'm going to have action potentials all the way down, one after the other, and this slows down transmission of my neuron. So my patient can have transmission down that neuron so they're able to do things they used to not be able to do. Like, for instance, they may have problems with vision. And then all of a sudden those vision problems go away, but I'm not quite back to normal. Or they might have been having issues in moving the muscles of their legs, so they have a very hard time walking, but then all of a sudden they have remission because these voltage gates have grown, and now I can walk, just not as well or as fast as I used to be able to. Now here's the other big issue. After those gates grow back, they don't stay. They're not supposed to be there. We can't maintain them, and they will start to go away over time. And now the MS issues come back full force and basically remain with that person. So that's why we call this the relapsing remitting course. So oligodendrocytes for a while can also remyelinate the axons. And then what will happen is you get these big areas of demyelination because the oligodendrocyte is they just can't keep up. They can't do this anymore, and we call this plaque. As the disease progresses, there's less improvement between the exacerbations, increasing neurological function, which is what we just talked about. So this is MS, and there is plaque buildup here that is occurring, and then also all around here we have all this plaque buildup. This is not supposed to be so dark around the ventricles. So again, we don't know what the cause of MS is. It could be genetics, which a lot of people believe. Females get this much more than males. And there is a part of our MHC, or human leukocyte antigen, called the DR2 region. And this region is very susceptible to autoimmune diseases. Now, it could also be environmental. And so you have certain toxins that could bring on MS, or like many autoimmune diseases, we think there is a genetic component that is kind of tripped or activated by environmental factors. So for instance, some kind of massive stress, radiation poisoning, some kind of toxin that occurs from a virus, can then activate parts of our DNA, like the HLA-DR2 genes, and then MS starts in a person. Even low vitamin D levels can trigger these genetic issues to start MS. So there's no cure. Treatments are used to try to blunt that autoimmune process, like corticosteroids or cyclophosphamide, and even intravenous immunoglobulins. Plasmapheresis can occur, which is we're trying to take all those extra antibodies out of the blood. And so here is a video on MS I'd like you to take a minute to watch.
Multiple sclerosis, MS, is a disease that affects the central nervous system, the CNS, which consists of the brain, spinal cord, and optic nerves. Everything we do, whether it's taking a step, solving a problem, or simply breathing, relies on the proper functioning of the CNS. To understand how MS may impact the CNS, we must explore the disease at the cellular level. In the brain, millions of nerve cells called neurons continually send and receive signals. Each signal is a minute but necessary part of intricate CNS orchestrations that culminate in the actions, sensations, thoughts, and emotions that comprise the human experience. Normally, the path over which a nerve signal travels is protected by a type of insulation called the myelin sheath. This insulation is essential for nerve signals to reach their target. In MS, the myelin sheath is eroded, and the underlying wire-like nerve fiber is also damaged. This leads to a breakdown in the ability of the nerve cells to transmit signals. It is believed that the loss of myelin is the result of mistaken attacks by immune cells. Immune cells protect the body against foreign substances, such as bacteria and viruses. But in MS, something goes awry. Immune cells infiltrate the brain and spinal cord, seek out the myelin, and attack. As ongoing inflammation and tissue damage occurs, nerve signals are disrupted. This causes unpredictable symptoms that can range from numbness or tingling to blindness and paralysis. These losses may be temporary or permanent.
Guillain-Barré Syndrome is an autoimmune disorder, and it has been linked to different viruses like cytomegalovirus or Campylobacter jejuni, Epstein-Barr virus, and it's common in both male and female between the ages of 30 to 50. It leads 5, 4, 3, 2, 1. Guillain-Barré syndrome is an autoimmune disorder that has been linked to things like cytomegalovirus and Epstein-Barr virus. I don't know if you remember, but a few years ago there was a vaccine that came out for the common cold, I believe, and people who received that vaccine some people ended up getting Guillain-Barré syndrome from that as well, although the government said that that wasn't the case, but there is a possibility that it was. So it's very common in both males and females. Quite often it strikes someone between the ages of 30 and 50. The autoimmune system part of it is attacking the peripheral nerves, and it's resulting in demyelination of those nerves and conduction block. So it leads to inflammation of the nerves and therefore muscle weakness. Now, new myelin sheaths can form, but they're usually more thin and they're subject to injury after formation. So symptoms of Guillain-Barré would be rapidly progressing limb weakness, loss of tendon reflexes, flaccid paralysis, acute peripheral neuropathy, and then of course, more progressive weakness occurring, and then may lead to death due to ventilatory failure and autonomic disturbances. Now, quite often, your patients from Guillain-Barré can end up in a wheelchair as well. So it's usually self-limiting, and many people who get Guillain-Barré syndrome can come back from it and they don't have it anymore and they're fine. But there can be disturbances in the respiratory muscles, and this requires respiratory intensive care, which then may lead to death. Treatment for Guillain-Barré would be plasmapheresis, again trying to get those antibodies out of the system that are attacking the myelin sheaths. There's intravenous immunoglobulin therapy, and then 80 to 90% achieve full and spontaneous recovery in about 6 to 12 months. Alzheimer's disease is the most common cause of dementia in the elderly. It is a neurodegenerative disease, and what you see is the cortex of the brain begins to atrophy, and this is because of neuronal loss. Microscopically, when you look at these brains, you're going to see what are called neurofibrillary tangles and neurotic plaque, which we're going to talk about. So one of the things that our neurons produce in the cell membrane is referred to as amyloid beta protein. Now, one of the problems with this is that if this beta protein is broken down incorrectly because of certain enzymes in a person's body, these proteins can build up and create plaque that forms in between neurons. And so these neurons, first of all, if it's forming in between, you're talking about in the synaptic cleft, and neurotransmitters can't transmit information from the pre to the postsynaptic neuron. The inflammatory response is obviously not good for the neuron because one of the things that you see happening are cytokines are being released into this area, and it can create problems with transmission of these neurons as well. In this micrograph, you can see some buildup of an amyloid plaque, and there's more right here. This is just the buildup of that protein that occurs in the synaptic cleft. Neurofibrillary tangles are due to interaction of what's called a tau protein. Now, tau proteins are used to stabilize microtubules, and microtubules are kind of used like railroad tracks and help to ship nutrients throughout our cell. But what happens is you have this enzyme called protein kinase, which, by the way, protein kinase is found all throughout the body, and its job is to transfer phosphates. And so the protein kinase takes a phosphate and attaches it to the tau protein. When that happens, the tau protein now becomes defective and it can't stabilize those microtubules anymore, and the microtubules become tangled. And so if the microtubules become tangled, they can't transport things within the cell. And so that's what you see here is this is the microtubule, and it begins to disintegrate, or you have like these clumps of tau proteins, and the microtubules can't stay together anymore, which if you can't transport things from one area to the next inside a neuron, that neuron is not going to survive. This is also showing you some plaque as well as neurons that are starting to degenerate in comparison to just healthy neurons. It's a little cartoon to let you see this. And then here is an actual micrograph, and here we see the plaque build up between neurons, and then this is showing you the tangles that can occur. And inside here, that neuron does not look healthy at all. So these neurons that have tangles are going to go through apoptosis. And when that happens, you're going to have brain atrophy. So the gyri of the brain become narrower, the sulci become deeper, the ventricles also enlarge in Alzheimer's disease. And so these are some of the things that you can see in an individual after autopsy has occurred to be able to say their type of dementia was actually Alzheimer's. So this is the much larger ventricle that occurs, and then you can see the gyri and the sulci, the changes that occur there as well. Here's advanced Alzheimer's, that you can see definitely the atrophy that's occurring. You notice the sulci, how much deeper it is, and the ventricles, how much larger they are. And this is an actual picture of a brain after autopsy. So this is one of the things to show you the progression of this disease. A big deal is in the memory region, which has to do with the hippocampus and the amygdala. It also is in the area of the cerebellum, and you can see the progression as it takes place with atrophy and death of those neurons. So Alzheimer's could be caused by genetics, could be environmental, we don't really know. There's an early onset Alzheimer's, which is probably genetic. Late onset Alzheimer's could be definitely environmental. There is a protein called an apolipoprotein E. This protein helps to break down that beta amyloid we were talking about before, but there's a genetic defect in producing apolipoprotein E, and that could be what prevents the breakdown of the beta amyloid, and you get those amyloid plaques building up. So the early symptoms of Alzheimer's, they lose their short-term memory, and they're much more forgetful. They have other memory disturbances, but typically long-term memory is still in place. They have language deficits, their motor skills are lost, they can have mood, behavioral changes, and be very disoriented. I don't know where I'm at, I don't know who you are, that type of thing. And then eventually the patient becomes much more disabled. They can become mute, they're immobile, and then you really know when it's getting bad when they lose their long-term memory. Most common cause of death for Alzheimer's is an infection such as pneumonia. Unfortunately, no cure. Components of the peripheral nervous system include a motor and sensory, and these are from branches of cranial and spinal nerves, and the peripheral parts of the autonomic nervous system as well. You also have what's called peripheral ganglia, wherein the cell bodies of our neurons are grouped together. So in the peripheral nervous system, we refer to these as ganglia. In the central nervous system, we call these nuclei. Disorders of skeletal muscle groups. First, we'll start with muscular atrophy. So a normal cell is innervated by the motor neuron. And in muscular atrophy, something is typically happening to that muscle so that the muscle is shrinking. And part of it could be the innervation, but part of it could be that there's something wrong with the muscle. But atrophy just simply means that the muscle itself is shrinking in diameter, it loses its contractile abilities because it's losing its actin and myosin, and so the muscle becomes very weak. You also have what's called muscular dystrophy, and this is a genetic disorder, and it produces progressive deterioration of the skeletal muscles, and this is because of mixed muscle cell hypertrophy, atrophy, and necrosis all happening. So in muscular dystrophy, the dys means bad, the troph means nourish, and so that muscle isn't being nourished appropriately. So the muscle is damaged, but the motor neuron is fine. Now, what we see in muscular dystrophy is the mutation of what's called the dystrophin gene. So you don't have the protein production of the dystrophin protein. So this is an inherited recessive disorder, and it's on the short arm of the X chromosome. Now, dystrophin, which is not being produced appropriately, connects the Z lines to the connective tissue of the surrounding muscle. Now, remember, the Z lines are part of the sarcomere. So what has to happen, and this is really important, is the Z lines have to be connected to the connective tissue on the outside of the sarcolemma, or the muscle cell membrane. That connective tissue eventually is going to pull on the tendon and help the tendon, as the muscle contracts, to move the bone. So the Z lines are initially moving, and they're moving, pulling on the dystrophin. The dystrophin is pulling on the connective tissue outside each individual muscle cell, and then those muscle cells are pulling on all the connective tissue that connects the tendon to the muscle and to the bone. So if you don't have that dystrophin to connect the Z lines to the sarcolemma and that outside connective tissue, you're not going to be able to get bones moving or the muscle as a whole to move. So you have breakdown of the sarcolemma also, which can lead to necrosis of the muscle fibers. So the first type of muscular dystrophy we're going to talk about is Duchenne's muscular dystrophy. 1 in about 3,500 males are born with this. The symptoms usually don't start presenting until around the age of 5. There's slow progressive onset of muscle weakness, and this is due to muscle atrophy. So you can see in the picture that the person goes from being able to stand erect, okay, in this picture here, to they start having this slumped posture, and eventually over time they end up in a wheelchair. They can also have cardiomyopathy and eventually cardiac failure from this. The symptoms include fatigue. It may lead to mental retardation, muscle weakness, which actually begins in the legs and the pelvis, difficulty with motor skills like running, jumping, hopping, frequent falls, and then again, maybe confined to a wheelchair by the age of 12. Some of the signs of Duchenne's would be abnormal heart muscle, congestive heart failure, arrhythmia, scoliosis, respiratory disorders, muscle wasting. Treatments, well, there's no cure for this because it's genetic, but the treatments aim to control the symptoms at this point and anything that would maximize the person's quality of life. Now, gene therapy may become available in the future, and of course this means being able to genetically modify the human prior to the single cell becoming 2. Another type of muscular dystrophy is called Becker muscular dystrophy, and it's very similar to Duchenne's muscular dystrophy, but it gets worse much slower than Duchenne's. You have about 3 to 6 out of every 100,000 males who will have Becker's muscular dystrophy. It is an X-linked chromosomal disorder, and it manifests between the ages of about 10 to 20. So looking at Duchenne's versus Becker's muscular dystrophy, the two of them are both X-linked recessive disorders. They both have a decrease in the production of the protein dystrophin. Patients have progressive weakness, and that causes severe disabilities. So they have difficulty walking, they have difficulty with posture, frequent falling, dilated cardiomyopathy can occur, and early death is due to respiratory insufficiencies. So to help these patients, exercise, very important, active and passive, along with braces for the legs, and then ankle and foot orthotics to help with walking. In Duchenne's dystrophy, prednisone might be able to be given in order to improve muscle strength, pulmonary function. It can also delay the onset of cardiomyopathy because that is decreasing inflammation. ACE inhibitors or beta blockers can slow the progression of cardiomyopathy as well, and then eventually ventilator support may be able to help prolong life. Myasthenia gravis. This is a disorder of transmission at the neuromuscular junction so that communication between the motor neuron and the muscle itself is breaking down. The cause is an autoimmune disease, and antibodies are being produced against the acetylcholine receptors that are at the neuromuscular junction. These cholinergic receptors are binding the neurotransmitter acetylcholine that's being released from the motor neuron. But the antibodies are now destroying those receptors, and so you can't bind the acetylcholine, which means you can't innervate or activate that muscle. So this is being sensitized by the helper T cells, and we have those antibodies directed against the receptors. Muscle weakness occurs. The person fatigues very easily with any type of sustained effort. One of the big deals that you can see with people with myasthenia gravis externally is that they have ptosis of the eyelid. So the eyelid is drooping because the muscles are weak. The person has diplopia, which is double vision, because those muscles are weak as well, helping to keep the eyes from progressing inward. And just overall, they have general weakness to the point where if they have a myasthenic crisis, they can have weakness so bad that even respiratory muscles are not working, and so they have to be put on a ventilator. Now, because this is an autoimmune disease, periods of stress can create issues with the immune system and cause the immune system to go out of whack even more, and that person can release even more antibodies and create problems with the receptors. Now, this shows you ptosis of the eyelid very nicely. And the person, notice how they're trying to pick up their eyebrow here to try to get the eyelid to open up more. So in order to diagnose myasthenia gravis, there is something called a tensilon or edrophonium test. And what happens with this test is you give the person acetylcholinesterase inhibitor. And so remember, that's the enzyme that breaks acetylcholine down in the neuromuscular cleft. And so we're going to keep that enzyme from destroying the acetylcholine. So once it binds to the receptor, it can fall off and bind again and fall off and bind again. And so we can get a better stimulation of the muscle. So what you see with these patients is it's just phenomenal. You give them this inhibitor and all of a sudden their muscles all work. You could have a patient who is in bed and within just a very short period of time, all of a sudden they're standing up and walking around until this inhibitor wears off. So the patient feels little or no weakness for a very short period of time. Now you can also test for what's been called MuSK antibodies. These are the name that we give to the antibodies that are being made against those acetylcholine receptors. So let's watch a little video about the edrophonium or the tensilon test. So notice how much difficulty the dog has in being able to walk because of this myasthenia gravis. We're just going to demonstrate by walking the dog around a little bit. And it fatigues very quickly. All right, so now they're going to administer through an IV the inhibitor and then follow that with a bolus of saline to make sure that it gets into the dog's system. And anytime you're doing that, you saw the dog kind of flinch because she went a little too fast. That can be painful, shoving that bolus into the venous system too quickly. Okay, now they're going to walk the dog around again. And there you go. Now you know for sure that that dog has myasthenia gravis. And what the owner will need to do is give that dog inhibitors in the form of a pill for the rest of her life. All right, well, thank you for being here again for this video, and I will see you next time.